Thank you all. Thank you very much for enabling me to be part of this and to WorkSafe New South Wales, who I've been involved in quite intimately over the past few months, putting together some of the evidence behind the programs they are implementing now. And one of the key reasons why I am more of an academic than a clinician is I grew up surrounded by very serious mental illness. First time I met my grandmother was when she was discharged from an asylum after 20 years as an inpatient, having tried to kill my mother and her sisters. My brother had an early onset of a very serious mental illness, and I can count the number of the amount he's worked over his life in weeks rather than months, and he's 49 now. And it struck me over the time growing up and later on that many good people, very many well-meaning people, do things that they think are good and seem nice, but are not necessarily very effective, and that different things are differentially effective. And we talk about things like treatment. We talk about treatment after PTSD, but we know, for instance, that some things are really quite effective, some things have no effect whatsoever, and some things can actually be harmful. And so I'm really keen that we actually introduce this kind of approach to what we're talking about when we talk about mental ill health. And I'm going to use the word mental ill health because I was working at the World Health Organization when mental health became something that you aspire to. And it's interesting, we do a lot of work out in the field now, a lot of work with people, and mental health is now something that means mental ill health. It's interesting the way the words have changed over the past just 2 decades. These are the various people who pay me to do bits of research and consultancy in various areas. And I would also like to disclose that I was actually one of the authors of the UK's health safety standards and did the initial evaluation of those over 15 years ago. And we too have a model much like the Canadians, and this comes from some work we've been doing over 20 years, and Sam Harvey, who's over there ignoring us, has been involved in this. And we too talk about this concept of a healthy worker with no mental health problems, people who are symptomatic, or importantly, maybe at risk rather than necessarily have symptoms, some of whom may go on to mental ill health, some of whom may have sickness absence. And there is not a one-to-one correlation of dysfunction with symptoms. Some people may be highly symptomatic with very little dysfunction. Some people may be highly dysfunctional and impaired at very low levels of symptoms. And we think about intervening at different levels around job design, primary preventions, secondary preventions, looking at protective factors at the organizational level, and individual factors, then thinking how we can facilitate early help seeking and how we might help with an individual in terms of recovery, getting over the mental ill health and getting back to work and functioning, and think about the interventions in those areas. And in this kind of work, I've been really helped with Sam, as my colleague over here, and Rafael Calvo. A lot of this work has been funded as part of the Well at Work program funded by Beyond Blue, who are here today, and I'd like to thank them for some of their support in that. And really, it's about an evidence-based approach, an evidence-informed approach of what we know works and what can work, and to produce the evidence about this. And we've heard a lot here about the work-based risks for mental ill health. And we kind of break them down into sort of some job design factors, and you've heard about complexity and demands and change and control. And then there's some about the actual employment status. What kind of occupation do you have? There are some occupations that are inherently very risky if you're a first responder. I've been physically assaulted in the workplace on a psychiatric unit. These places are inherently dangerous, or inherently carry more risk. Insecure jobs, the precarious, casual workforce. And then there's things about the social relations at work, such as bullying, social support, and insecurity, some of which you can measure objectively. We know how many hours people work, for instance. We know whether someone has an insecure employment because they might be on a casual contract, some of which are measured at an individual level, and some of which, and we've heard a lot about the psychosocial safety climate, which I think is a really interesting approach, which I tend to view as a macro-level risk factor, and I know Maureen has a view that we can measure it at different levels. And so we can think about these things at different levels, and often much of the literature really hasn't picked apart those different levels of risks. And we do know that some of these risks are getting worse over time. This is the OECD data, which basically shows in the grey bars that job demands and job strain actually has been increasing in virtually all OECD countries over the past 10 to 15 years, whereas some are really not really changing that much. You may not believe this from the reports, but actually the number of hours worked by the average Australian worker has in fact been going down over the past 50 years. So risks are changing, and they're changing in the societies we are. And there are many other demands. We talk about the intrusion of technology at home, so that the hours we officially work have actually become much greater in terms of the hours we work because we do the unofficial work, and you'll sit there on your phones all the way through lunch and other areas. And casual work. Casual work's been with us for a long time. 1/3 of Australians are employed part-time, and about 1/4 of Australians are employed casually, and that hasn't really changed very much, certainly over the past 15 to 20 years. So these are the individual risks, and what I'm keen to get across here is we often talk about whether something is a risk factor, but the key thing is how strong a risk is it? Is it a very strong risk? Or is it a weak risk? And here I'm going to try and give you some ways to think about this. So when we take one of the biggest Australian data sets around this, and a lot of the data comes from here, it's something called the Hilda data set. Now, the wonderful thing about the Hilda data set is it has 15 waves of data. There are 10, 12, 13,000 people each time. And importantly, no one knows that it is asking them specifically about their mental health or ill health, or about aspects of their job strain and job stress. It is all framed in a different context. So it removes many of the kind of biased responses you might see in other areas. So it's a really wonderful and rich data set. And within that data set, we see that about 1 in 8 employed Australians have a level of mental ill health that is considered significant using a standard measure, standard cut point. That's employed Australians. Remember, unemployed Australians have much higher levels of mental ill health. Always remember, mental illness and mental ill health is much more common in the unemployed. And again, much of what I'm talking about here doesn't really reflect those with severe mental illnesses like schizophrenia, only 20% of whom have a job in any 1 year in Australia. Our employment rates of people with severe mental illness are woeful, and actually particularly woeful compared to much of the other OECD. And if you take there is always what's called a baseline risk of becoming unwell. So I'll put these into the context. If you've got someone who has absolutely none of the known risks that we can think of for becoming unwell, over a year, about 5 or 6% of those people will actually develop a mental ill health problem. There are various other things that go on in their lives, various other aspects. So that's what I call the base rate. And so when you think about these risks, you've got to think about how that changes the base rate. How many more people, what greater proportion would become unwell over that year who are currently healthy, and that's how you think about the risks. And if we take the job demands and job control, if you take that base rate of something and everything else all being equal, instead of about 5 or 6% of people becoming unwell over the year, about 7 or 8% of people would become unwell over the year if they had high levels of job demands or low levels of job control. So it increases the proportion by about 2%. Those risks combine. And we talked about the job strain model. So if you have high levels of job demands, as I do, and probably many of the people around this room, and I'll show you those in a second, and low levels of control, and I have high levels of control, I'm free of that particular risk, then that doubles your risk. So about 10, 12, 13% of people with that particular profile will become unwell over the period of a year. Low support, that increases your risk by about 20% to kind of 7% of people will. The effort-reward imbalance has a similar effect to high levels of strain. So again, 10, 11, 12% of people would become unwell just with that risk. The effect of organisational change is the evidence for that is surprisingly limited, that organisational change has a significant and consistent impact on poor mental ill health. And this evidence comes from a huge evidence review that I did one for SafeWork and Sam also did previously. We've taken data from 5 systematic reviews, meta-analyses. These have reviewed the worldwide literature on these prospective studies. And some of these include, hundreds of thousands of people, 10, 15, 20 studies. These are big reviews of all of the literature, not quoting an individual study that supports your thesis, but taking all of the data. Long hours, surprisingly, there is very little evidence that long hours, up to about 50 or 55 hours, actually increases your risk of mental ill health. Admittedly, quite a lot of that data comes from Japan, and their idea of what long hours is a bit different than ours. And as someone who works 55 or 60 hours every single week, I'm quite pleased about that. It doesn't really appear so much. Shift work is kind of interesting. There's several papers of looking at shift work in healthcare workers, all of whom have shown no increased risk in mental ill health. But all of the papers on shift work in non-healthcare workers have shown an increased risk. There appears to be something different around those two groups of people. Organisational injustice has a small effect, but again, it's inconsistent. And job insecurity increases your risk from 5 or 6% up to about 7 or 8%, as does temporary work. So that gives you a ballpark of what those risks are and what the impact would be if you had those risks. And that's important for when you understand what the benefits might be of intervening on those risks. So, not all jobs are the same, as hopefully I've just pointed out. So, what about the risks in different occupations? And what we've got here is, this again is taking that data set and looking at the people in these different roles, in different occupations, those who have much higher levels of demands than the average Australian, and those who have lower levels of demands. And here you can see high demands are really concentrated in managers and professionals. They're concentrated in the senior group of people. They are much more likely, whereas low demands are seen in sales workers, machinery operators, and labourers. There's a group here at the bottom called frontline workers I want you to concentrate on. This is comprised to a large extent of first responders and security guards, people who have much higher inherent risks in their occupation, and particularly for men, very high levels of demands. Insecurity is concentrated where you would expect in machinery operators and labourers, and of course managers and professionals have very low levels of insecurity. We have nice, we have jobs that tend to be permanent. And again, the managers and professionals tend to be incubated from control. We tend to have very high levels of control. The fact that you're all here and not doing your normal job for most of us and can get these 2 days off to come and sit here and do this just shows what a level of control most of us actually have about our job. And the low levels of control are concentrated in this workers. And again, note, very low levels of control in these frontline workers, constantly responding to demands. If you look at the industries, you can see again there's differences in the industries. So the high demand industries, IT, finance, professional services, public admin, education. And again, many of the areas, construction, trade, retail, servicing, low levels of demands. Low security, mining and manufacturing. Interestingly, so lots of casual, precarious work and construction, particularly women, and there aren't many of them. And low control, well, these are people who have good outcomes, good low control. There's no real industry that appears to be very bad for control in Australia. There are several that appear to be okay. But as we've heard, and we heard from Caroline, people are not a tabula rasa. People bring their own selves to the workplace. And we've done some risk prediction modelling, and what we've confirmed, as is confirmed in data from across Europe in primary care, and from Canadian studies in both Canada and America, is almost the biggest predictor of mental ill health later on at work are 2 things: previous mental ill health and discrimination and stigma, regardless of what that discrimination and stigma comes from. So people bring things to that. And this is seen probably best. These are our risk prediction models. And here we're showing that really, this is the centile of men. So basically, this is the 10% of men who have the highest risk. So they have about a 1/3 chance of becoming unwell in a year. And there's a whole group who have around a 5% chance of becoming unwell in a year. And we're using this modeling to actually help us understand who really is likely to become unwell and what those factors are. And it's probably exemplified most in this concept of bullying. So this is by far the biggest and best study combining the world literature on bullying. And what this shows, and the top part here, is these are the 22 studies that looked at if you were bullied, what was the likely, how strong was the effect of going on and getting problems with mental ill health, defined overall, or depression or anxiety and stress. And they're reasonably strong correlations. And look, these are studies with 50, 20,000 people in them together, particularly for depression. But interestingly, there was nearly as strong an effect on having prior mental ill health problems on later reporting being bullied. So we really need to think about, when we think about what mentally healthy workplaces are, to think about mentally healthy workplaces for people who've had problems previously, people who are well now. And those 2 things, what we do may be different for different groups of people. People have different risks. These are the data we've used, and I'm just showing you where the cut points are. What about mental ill health? I'm talking mental health here. The ill health is the red ones where there's more ill health. The green is where there's less ill health. The severe group, this is the people who have about on average, would have about 8% of the population have employees with severe mental or severer mental ill health. And here you can see the managers and the professionals have low levels of mental ill health. And they're the ones who have the high levels of demands, interestingly, but high control. Whereas you see the higher levels higher levels of mental ill health in those groups of people who have low control, the sales workers, the machinery operators, the labourers. And here you can see the double whammy. If you've got a physical health condition as well as your physical health condition, again, a huge contributor to the likelihood of having a mental health problem, which is nothing to do with work, but interacts with the problems at work if you have both of those. Again, in the different industries, we see the severe ill health. Now, the females here actually become quite small, so take the figures in italics with a pinch of salt because there's so few women in some of these cells. But again, so we see low levels of severe mental ill health in agriculture, low levels in mining, which is somewhat surprising in these data compared to what we hear, low levels in IT and transport in some areas, and much higher levels in the retail trade, accommodation and food services, often jobs where high levels of people who may have problems previously, lots of other social demands on them, lots of other things going on in their life as well. And how does that work into the cost? And here what we've done is, what are the costs of mental ill health in these different occupations using these data? And here we've modeled the costs, looking at the costs. This is the cost of absenteeism. The slides have gone a bit wonky here. So the HILDA data probably slightly underestimates the absenteeism costs. So the costs will be slightly higher for absenteeism, and it probably overestimates the absenteeism costs. But here we see that if you take the severe mental ill health, although the managers have low levels of mental ill health, they cost a lot, because when they go off, they cost an organisation a lot of money. Whereas, for instance, community workers tend to be get paid far less, and so when they go off, they actually cost the organisation far less. So the costs are highly bound up with not just what the prevalence of ill health or the prevalence of risk, but very, very highly bound up with the amount that people are paid and what their contribution is. And so that really dramatically changes the cost to different industries. And if you're an industry with very high wages, illness is going to cost you a lot more than if you're in an industry with low levels of wages. When we look at presenteeism, again, we can see the costs are really concentrated in the managers and professionals. And in terms of the presenteeism here, you remember, so presenteeism isn't all around mental ill health. 1 in 5 Australians report a degree of presenteeism over the past 4 weeks. That is, they go to work and they're not performing as well as they should do. They're not completing their tasks as well. They're really not engaged in the workplace as well as they could be. 1 in 5 people report that. If you've got a moderate mental ill health problem, that goes up to about 1 in 3. If you've got a severe mental ill health problem, that goes up to about 6 out of 10. So these people with the severe problems report much, much higher levels of presenteeism. And so when we look at the overall workplace costs in New South Wales, so these over here are the compensation claims. These are the costs for compensation claims per area. And here you can see what's interesting is the frontline workers account for almost half of all of the New South Wales workers' compensation claims. So there is a disconnect between workers' compensation claims and actually where some of the stresses of mental ill health is. There's something else going on that is around the organisation and what else happens and the responses of the system. And these are the overall costs, and these are the costs in thousands of millions. So we've estimated that about 2.5 billion cost to the employers, just purely on the basis of presenteeism, vastly outweighs the costs of a few hundred million related to absence and workers' compensation claims. We've probably slightly overestimated that and slightly underestimated the absenteeism costs, but even allowing for those changes, the costs are really in presenteeism, and those are what's called marginal costs. Those are the additional costs that people with mental ill health have over and above what would be expected from the people who do not have a mental ill health problem. Because remembering, everyone has some risk of all of those. And then what works? So we've done some systematic reviews around what goes on. And again, this has been left by some of Sam's team and some of our team. And this is a meta review. And here we're hampered by whether or not the data is really there, that there are enough data for various interventions. And we've identified over 20 different interventions that have been evaluated independently that have some evidence about whether they work or they don't work. And it's interesting how many interventions are not evaluated at the level that we would expect, for instance, in health services, for us to start to be implementing things in health services. The idea of controlled trials or randomized controlled trials and cluster randomized controlled trials. And people often say, you can't do those. They're too difficult. Well, I've done randomized controlled trials of anti-stigma interventions in organizations. You can do them. Sam's completed a cluster randomized controlled trial of manager training in organizations. You can do these things, and they do provide really good levels of evidence, and actually they can really change things as well. So one of the things I'd exhort people to do is to try and up our level of evaluation and research to actually generate more evidence. It's interesting, the job design ones, there's several controlled trials, there's sorts of before and after studies. It's very difficult to find any systematic review of randomized controlled trials of job design interventions coming out of the literature. It's an area where we really need to try and enhance actually our knowledge of what works at a higher quality of evidence. There's lots of good pre-post studies, there's lots of good beacon studies, there's lots of good studies about an organization, but we really need to be upping our level of evidence there. The colours here reflect the evidence. So, there's limited evidence in the brown, the green is where it's good, and the black is where we don't have it. Teamwork support interventions, some limited interventions there, really around, really one prospective study. We couldn't really find any reviews. Mental health and anti-stigma interventions, 11 of them, really good randomized controlled trials. They do increase the knowledge. Only 2 of the studies have actually looked at whether it actually makes people feel better, whether it improves their mental ill health, and both of them did show that. So there's a good increasing evidence base there. What about manager training? This is one of Sam's PhD students. Interestingly, manager training, if you do the systematic reviews here, and this is the diamond you're looking for here. If this diamond goes is further over to this side here, so above 0, then that improves knowledge. If it goes that side, it disproves knowledge. And this is a way of accumulating all the information. So manager training is pretty good on all the randomized controlled trials on improving knowledge, and it's pretty good on improving managers dealing with mental health issues. So they get more confident and improves their knowledge. However, it appears so far to have no effect, no knock-on effect on improving their employees' perception of their supervisor support, their psychological distress, or their absence. So we really need more evidence here about the impact of manager training actually on the outcomes which we care about, which are employees' outcomes, until we get this study here, which is just presented by my colleague Sam in Lancet last week. Really interesting cluster randomized controlled trial showing that actually within this organization, am I allowed to mention the organization? Yes, Fire and Rescue New South Wales, really fabulous design, cluster randomized control, really high level of evidence that actually this study reduced sickness absence. So working with managers, reduced sickness absence and was highly cost effective. For every dollar they spent on this, they probably got $10 back. So we're beginning to get the evidence now if we do it in a strong way. Enhancing personal resilience, so the workplace health promotion, CBT stress management programs, I've always been a bit cynical about actually do work. Mea culpa, I've changed. Academics are meant to be open-minded. Cynics, I'm an open-minded cynic, they work. And mindfulness programs as well. All these 3 things appear to have really good, consistent evidence that we can enhance personal resilience. And we can do this in high-risk organizations with CBT and workplace physical activity programs. Also, good randomized control evidence that workplace activity improves mental ill health. Facilitating early help seeking. So far, the evidence is quite limited. Well-being checks, really no reviews, really very little to show that well-being checks have any significant effect on improving employee health. Mental health first aid is really good at improving knowledge, decreasing negative attitudes and increasing supportive behavior, but really very little evidence that it actually then goes on and has an effect on employee mental health. But I do know that the people who are organizing those actually are moving on that and actually trying to generate those evidence. Now, peer support schemes, there's limited evidence, is EAPs. Now, EAPs are kind of interesting because the data on EAPs is there are several good randomized controlled trials of EAPs. They're actually all randomized controlled trials of clinical psychology interventions of 12 sessions of clinical psychology, not what is standard EAP practice. And actually, there's very little data to show that EAPs, in terms of standard practice, have a dramatic effect on employees' mental health. Again, an area where I think, given the amount of money spent on it, we really should be looking to bolster the evidence. And then what about what clinicians do? Well, we do know that work-focused interventions, facilitating return to work through work-focused support, can reduce sickness absence. Work-focused psychological therapy, that's not what many of us do. Many of us do the psychological therapy, which is standard, clinical CBT, etc., which doesn't focus on the work. And if you look at Mike Nicholas's studies with back pain, he's shown that work-focused return-to-work programs, which don't really do the standard approach, but look at work, they can improve people's return to work. And for those of you who are doctors, medication appears to have no effect on getting people back to work whatsoever. What about bullying? And here I was really disappointed. There is very little good evidence that we can do much about bullying. There's a lot of talk about it. There's a lot of programs, there's a lot of policies. This is the Cochrane review about that. They found only five decent interventions that they could really say were well done. The Crew intervention, which I think looks at some effect, that did increase civility by about 5%, had a small effect. And in one of the two studies, it had effect on absence, but not in the other. A very small study, an expressive writing task, had an effect. And by far the biggest study, a huge, great 5-organisational study in the UK of a randomised controlled trial of a multi-level anti-bullying study looking at education and policy, had no effect. So again, we're really in an area where we really need to bolster knowing what actually works in the bullying sphere. We've got a lot of policies, but we really don't know very much about what we should be doing underneath those policies. And what about digital interventions? This is in Nature. So when this Nature paper was published 2 years ago, there were 1,500 depression-related apps that you could go and buy on the App Store. Companies are buying these things. Companies are paying people to develop these things. They're implementing them. They're providing them to the employees. Back then, only 32 of those things had any evidence that they worked at all. And so we did a review of all of the evidence for workplace digital interventions. And here we showed, and what you've got here, this is the blue line here, anything that is right to the right-hand side of that dotted line. So all these CBT apps have been used in workplace settings and assessed there, all in randomized controlled trials. The CBT apps have a small but significant effect. That's a really quite small effect there. The mindfulness ones have really quite a large effect in short-term use. So the mindfulness one seems to be outperforming CBT. Stress management, very mixed effects. Some of the apps actually appear to be making you worse. So you really got to. What the take home from that is, don't just go and buy an app or a digital intervention that someone's coming to sell you. Ask what it is that they're selling you and what the evidence is behind it and does it work, because some don't. And here we looked at the return on investment. Now, the return on investment studies are always a little bit smoke and mirrors because a lot of them really depend upon the assumptions that you make. And here what we did is we took the evidence for the effectiveness, and we had strong evidence for effectiveness in some areas. So we took where we had the strongest evidence of effectiveness, which was interestingly exactly the same areas as came out in the Beyond Blue Price Waterhouse report, where we have the strong evidence for effectiveness. Where we didn't have the evidence was really around the interventions for job strain and job demands. And actually, we took a lot of the data from Professor Dollard's studies in Australia to actually utilise what would happen if, for instance, we achieved a PSC benchmarking of a certain of the amount she talked about in terms of reducing job strain by 14% in the Australian population. All the assumptions are in your documents here. And here we looked at the impact, for instance, of redesigning your job. And this is the impact on absentee days or presenteeism. And we divided this by small enterprises and large enterprises. And this shows you what the differences you could expect. And in a return on investment study, you put in what are the costs of delivering the study as opposed to what are the benefits in a pure monetary term. We've probably underestimated the benefits because we've only looked at employee-related benefits, not the knock-on effects into the health service, into families, into carers, etc. But that's always going to be the same. And here, I'm somewhat disappointed. Really, the individual-focused ones, again, just like the PwC Waterhouse report, even though we've used different data, you get an effect, you get about $1.6 to $4 back for every dollar you invest. The job design interventions proved to be cost ineffective at a universal level. They are not cost ineffective, particularly the job demand ones and job control, so they're not ineffective if you target them at high risk groups. So because the issue is when you're targeting them universally, lots and lots of people won't benefit, or rather won't have a cost benefit. Whereas if you target them at the high risk groups, you spend less and you have a benefit. So again, much with everyone else, I've been showing you the individual interventions. We need to think about how we integrate them, how we evaluate those integrations, how we manage to do those. And I can't do better than actually just literally put up the slide from the Beyond Blue report about what the success factors are and reiterate what everyone else has been doing. The implementation, managers, team levels, employee participation, policies, resources, etc., are vital to actually getting what we do know works into the workplace. Thank you very much.